last two presentations, which will be chaired by Dr. Ben Ragama, Deputy Director General of Laboratory Services. And we have two presentations left, Dr. Suranga Dulmullas and Professor Sanjoy Bhattacharya.
So it's been an absolutely fascinating experience listening to the first few presentations. I've already learned so much. I've taken copious notes, and I shall be using them the moment I get back to York to think more deeply about wider South Asian issues. But let me go back in time today for my presentation and look at how Sri Lanka has been presented, or Ceylon has been presented by historians of medicine. Now, British Ceylon, it has been acknowledged by historians like Margaret Jones, who has written widely on the subject, had tremendous improvements in health indicators thanks to policies that were introduced by locally elected politicians, who then were able to mobilize money for the training of health practitioners in the British period. And as Margaret Jones has pointed out, this resulted in British Ceylon being called the model colony. But it took this historian, Dr. Jones, a long time to get access to this material and actually write her book titled Sri Lanka, the Model Colony, and get it published in the 2000s. This was primarily because the history of medicine of South Asia, of 20th century South Asia, tended to focus too much on India. And the assumption amongst many North American and European academics was that it was sufficient to study the Indian case study, which would then, for them at least, represent what was happening in the rest of the subcontinent. But why Margaret Jones's work was so important was that she showed that this was not the case. She showed that local data needed to be studied, different British empires needed to be studied differently, and indeed we needed to understand why the indicators that we see in a state, Indian state like Kerala, are very similar to the indicators that you see in Ceylon or Sri Lanka, and there's a long history to the achievement of those indicators. Now, when one looks at the history of international and global health, reference to Sri Lanka is almost absent. And as a historian of South Asia and a historian of international health, that has been surprising me for a while. So I went and spent a couple of months researching the WHO headquarters' very rich archives, and as I indicated earlier, I started looking at the correspondence between the different WHO Director Generals, the WHO regional directors for Southeast Asia, and Sri Lankan government representatives from 1950s onwards. And what they showed me was, just as Margaret Jones had pointed out for the British period, that Sri Lanka was a very distinct case which needed to be studied in its own right. It became very clear after 1 week of work that Sri Lanka from 1948 onwards was actually playing an incredibly important role in reshaping and expanding World Health Organization. Now, for me, as a historian of the WHO, the World Health Organization is not a monolithic body. We often use the term WHO in an overarching sense, but actually the WHO is a very complex body, as I'm sure all of you know. It exists in Geneva, in the headquarters, but Geneva cannot talk directly to national governments. Geneva has to go through its regional offices. According to WHO Constitution, the negotiations that happen on behalf of the organization have to be carried out between the regional office and the national government. Day-to-day relationships between national and local governments happen with the WHO country office. Again, there are limits to what the regional office can do. Therefore, when I started looking at the history of WHO and the development of the Southeast Asia regional office, I started looking at the negotiations between Geneva, between Delhi, and then between Colombo and these two sites. And what was revealed was that from very early on, the government of Ceylon was highlighting in collaboration with the government of India, the importance of primary health care, universal access to health. But the government of Ceylon was the most powerful advocate for self-sufficiency in the production of medications, including antibiotics. Again and again, Ceylon's representatives in the World Health Assembly kept highlighting the importance of making sure that newly independent countries like itself needed to have independence of production, independence of supply. So whether it was Bandanaike or whether it was Chelappa, they were making the same point that just getting medicines or antibiotics from the West was not enough. What they needed was the capacity. They needed help to create factories in Ceylon or indeed other regions of Southeast Asia where a country's pharmaceutical needs could be met locally. And a point that the chair mentioned earlier today in his presentation, this was exceedingly important in a situation where access to US dollars for development purposes was in short supply. So the foreign exchange issue was something that is coming through right through the 1950s and 1960s. So this was at one level of historical analysis. Now, the other big problem, as I just discussed during tea with colleagues, is that a lot of history of international health is written on the basis of studying, and I say this advisedly, I'm saying this after much thought, by studying the thoughts and the actions of a handful, I mean 5 at most, men. And yet, the number of actors were many, many more the moment you go into the national level, and it certainly wasn't just men. So, what I'm trying to hint here is that the historians' biases, and they're not unconscious biases, the historians' biases in terms of race, in terms of gender, have limited the study of international health in South Asia. The study of international health of South Asia necessarily has to include the voices of Asian actors. Asian actors were not simply implementers of ideas that the 5 men in Geneva and United Nations presented to the world. The Asian actors, whether they were men and women, were actually coming up with innovative ideas based on evidence carried out locally, presented to different WHO fora, often accepted by the 5 men without attribution, and then put in a WHO report, was a complex process. So therefore, studying the end result and the 5 voices that shouted most loudly is not enough. So the question, therefore, as an academic, as someone who teaches, as someone who researches, and who is of Asian heritage but works in Europe, the advantage I have is that I can stand up in academic fora, as I am doing today, and say that no, research in multiple Asian languages is also important. So what happens when we adopt a bottom-up approach to historical research? So in relation to Ceylon and international health, the first thing that you see in the files between the WHO and what Sri Lankan actors are reporting to the WHO is that there is a demand for access to essential medicines. That demand for access to international essential medicines is not just a health-based demand, it's also a political demand. Bandaranaike is making that point constantly within the WHO, that this is a right, this is a fight for equity, this is a fight for justice. Access to medicines, no matter what your economic standing, is a health right. And slowly, other Southeast Asian countries or countries that form the Southeast Asia Regional Office start repeating his arguments, even though those arguments are not attributed necessarily all the time to him or the Ceylonese government. So as I pushed this research further, what is very, very striking is that when the WHO started off, it didn't have an essential list of medicines. It didn't have a department that would look after the updating of essential list of medicine. What the file shows us is that Sri Lanka took the leadership in the formation of the essential list of medicines within the WHO. And what really struck me, we were discussing again over tea, the importance of studying financial elements. If you as a historian follow the money, you often can start finding out very interesting things about the development of institutions and new departments within them. So if you follow the money in relation to the essential list of medicine, what you find out is stunning, something that historians have ignored till now, that countries like India and Ceylon in the 1950s and 60s are actually funding the development of new departments within the WHO headquarters and the WHO regional office. So this is not American money, this is not Western European money, this is Asian money, which is creating changes within the WHO, but everyone is keeping silent about it because there's politics around it. The Americans don't want to talk about the fact that the Asian countries are contributing because it is sending aid to the Asian countries. The Asian countries often don't want to talk about the many thousands of dollars that they're giving the WHO because the needs within their countries are so high, and there is an understanding that there might be domestic criticism about giving some of the money that is coming as aid back to the WHO for the creation of specific departments. So the ELM is actually a very, very important contribution made by Sri Lanka for the global community, for the international community. Now, why is this important in relation to AMR? When you look at these papers, what is very clear is that there was wide-ranging political support within Southeast Asia, the regional office, for the creation of essential list of medicine, but more importantly, the introduction of antibiotics into that list for all sorts of treatments, whether it's pediatrics or whether it's other fields. Therefore, if you look at this history in complex forms, what it suggests to me is that any attempt to control or change antibiotic uses therefore has to have a social and political engagement, because if medication, including antibiotics, is seen as a right and a mark of equity, just simple technocratic advice about rationality and its use is not enough. If you're going to limit the use of antibiotics, you therefore have to engage with society and political actors and explain why this is a need and not a denial of rights. And therefore, sir, what you said about multi-sectoral cooperation is very important, but interdisciplinary multi-sectoral involvement is precisely important because there is a role for sociologists and anthropologists to get us information that we can then use to involve ourselves in that engagement. So I end here now just saying that the way to a truly global history of global health is by increasing the number of viewpoints, increasing the number of languages and research, making sure that the information we collect is talking to each other from various directions. International health and global health was never the imagination of a small number of people imposed on the world. Whenever global health has worked, for instance, smallpox eradication, what those case studies show us is that it was based on multi-sectoral, international stakeholding, which involved all levels of society and politics. And therefore, perhaps, those are the lessons that can also help us create an effective coalition against antimicrobial resistance. So thank you so much.
Thank you, Professor Sanjay, for your very interesting presentation, where you touch upon the, especially, evolution of WHO, then the relationship between Sri Lanka and India, especially with regard to supply of drugs, local manufacturing. Of course, as we all aware, that 80% of our drug supplies are coming from India. Therefore, we are very much concerned about the quality, safety and efficacy of the drugs manufactured in India. Right? In that sense, of course, even in the antimicrobial resistance containment in this country, you have a role to play. Right? Of course, we have our own regulatory authority, but of course, as we are getting, as I mentioned, 80% of the drugs from your country, this is very important. Also, you talk about the essential medicine concept. Of course, we are very proud to say that Sri Lanka is the pioneer in this concept. Professor Senaka Bibili's name cannot be forgotten. He is the pioneer in this concept. And also, now Sri Lankan government has recognized the importance of manufacturing of medicines locally, and at the moment there are 24 companies, out of which majority are Indians, have signed agreements for joint ventures in Sri Lanka. Therefore, we will be moving towards the self-sufficiency of medicines, including antibiotics, so that we can closely monitor the efficacy, safety and quality of these medicines.